low.
I'm not as tachycardia up there.
Okay? So metoprolol, propranolol, nanolol, right? Tanolol. This is the low, okay? Remember, there's two types of beta blockers. Beta 2 and beta 1. Okay? Your beta 2 are your albuterol lungs. There's a beta 2 for 2 lungs and beta 1 for 1 heart. Okay? So, beta blockers are going to decrease heart rate as well. So keep in mind, if it has a blocker in it, it's going to mess with the heart. Okay? So heart rate. Okay? Propranolol is also used for your, what kind of patients have tachycardia? Thyroid patients, hyperthyroidism, right? They'll give them beta blockers to lower the heart rate. Okay?
Is there a frill or like little end for this one, like
Yes.
pine and all? It's one. That's it.
LOL.
Okay.
Yes.
Sure. Thank you.
Uh-huh. Like, I'll give you examples. Okay. Usually those are the two that they'll ask about ATS as well. Okay. So, the adverse effects for these will be bradycardia. Okay?
Huh?
Bradycardia.
Oh, yeah.
Yep.
That's the only one I know.
Yeah, me too. Only one I
I'm so confident about this one.
Okay, but for propranolol, okay, this one is going to cause bronchoconstriction. Okay? So, what patients do you have to monitor? Not monitor, but not give propranolol to? Asthmatic and COPD
Wait,
patients.
this is for.
You're going to kill them.
Wait, miss, is this an adverse? Is that's what it does, or it's like
What?
an adverse effect?
It's bronchoconstriction. It's also going to mask hypoglycemia.
What do you mean by that?
So, what I mean by mask, what do you usually see on your patient when they're hypoglycemic? Tremors, cold, tummy, right? Your patient is hypoglycemic, you're not going to notice that. You're not going to see that. That's what I mean. Okay? So you need to monitor them closely because you'll see signs and symptoms of hypoglycemia, right? Beta blockers are going to mask that. You're not going to see it. Very dangerous. Patient can be a 40, blood pressure be a 40, and you not know it because of the masking from the beta blocker. Okay? So monitor the blood sugar closely when they're on beta blockers. Okay? Is there anything you want to add about beta blockers?
Yeah. Another question that I've seen it do is, this is one of those medications that you have to also taper them off. So, they'll call it the adverse effect. If they wanna ask you what to do about it, they just how to taper it off. The technical name for the adverse effect is, rebound myocardium excitation. So what this means is once the patient begins to take this medication and they're on it, their heart becomes accustomed to the level. So it just generally slows down. This is given routine, obviously, for throughout. So then if they suddenly stop the medication or they start missing it, the heart no longer is like suppressed, if that makes sense. So what it'll do is it bounces back and with force. So they're gonna have tachycardia and their heart starts pumping really hard. We used to have an aide on here. His mother passed away from that. They didn't be careful from that. They didn't taper her off prior to her surgery, and they stopped her. And because of that, she just, like, her heart went kind of like whack. All right, so it does happen. You need to taper them off. So if they're gonna come off of it, you start slowly decreasing the dose, taper them off. If they miss a dose, right, it's really dangerous. Do not double dose them if they miss a dose. Just take it as soon as they remember, okay? And then just try to then align them back on their time slowly by like adjusting the hour. But don't double dose them. Don't just stop the medication suddenly. If they can't take it, if for whatever reason they need to stop it suddenly, notify the provider so that they can be aware and hopefully give them something to prevent this from happening. Because if not, their heart is used to being slow and more gentle. The medication is gone out of their system, and now their heart snaps back into motion, and it starts tachycardia, so over 100, and then really, really with a lot of force. Okay. So that's the last thing to remember. The key point again, they'll ask, can the patient just get stopped of his medication? No, taper them off, right? Or they'll ask you, what lets you know that the client understood the teaching, right? Like I can stop this medication anytime if I don't feel good. Like no. Okay, so things like that is how they phrase the question in regards to this. Okay, they can't suddenly stop it. Yeah. That's what I remember. And then as we said, it's not on there, but just know for all antihypertensives, all of them, like kind of what we were going over yesterday, right? How we say for all surgeries we're monitoring temporary infection. For all antihypertensives, if you look in your book, they all have hypotension or orthostatic hypotension as a side effect. That should make sense just from the fact that you know this is lowering their blood pressure. So what's a problem? It can lower it too much, right? Or when they stand up, they can lose their blood pressure. So that's just generic. Just know that anytime you know it's a antihypertensive, that should be something that's in your head, right? Hypotension. In the Pharm, in their math, like dosage count, there may be 1 or 2 at max, but it's not the focus.
They should put more.
Yeah, like these are free
Those
ones.
are easy.
So what's the antidote for beta blockers if there's too much? If there's too much, I don't think they have a specific one for it. Okay.
Dude, Robbie hair is very.
No, there's nothing for it in regards to like toxicity or that they're gonna like overdose if you give them too much. There isn't a specific aid for it. They'll probably there isn't a counter. They just kind of let it. Clean out either that or just try to keep your BP up. Yeah. Okay, sure. Thank you. Thank you. No.
Yeah.
Alright. So the next one that she wants to cover is angiotensin receptor blocker, also known as ARBs. The suffix is sartans, such as losartan. Okay? If you notice, this is very similar in name to the angiotensin converting enzyme inhibitor. So the difference between them is kind of in the name. While this one blocks the receptor for the angiotensin, the other one stops it a step before by blocking the enzyme that's going to make angiotensin 1 go to 2.
These are still blood pressure medication?
This is still a blood pressure medication. So you're going to notice that the adverse effects are very similar, just not as serious as the ACE inhibitor.
Is the suffix TAN for this medicine?
No, it's
Oh, the whole thing
SSARTAN.
is
Yeah,
sartan.
sartan. They always have like the sartan, candesartan, olmesartan. They always have the sartan, like the whole 6 letters. That's their suffix.
Thank you.
Okay. So in this one, just like we had mentioned in for the ACE inhibitors, I have angioedema. Okay. The hypotension, like we said, lightheadedness.
Adverse, right? Sorry.
These are adverse effects. Okay, there's not many for the sartans. They share a lot with the ACE inhibitor, but again, the difference between this one and the ACE inhibitor is this one does not have the cough.
Oh.
Okay. There's not much else to like go on it. That's not the same as ACE inhibitors. Other than this one, again, they're more focused on the hypotension, lightheadedness, and still the angioedema. The cough is not an issue, or the neutropenia, or the dysgeusia. That's for the prills.
And we can put them grapefruit juice with this?
With this one, yes. The grapefruit juice is again, or here I'll write them up here. The spironolactone. So no grapefruit, right? There's 3 that are very kind of like known for that, and it's the calcium channel blockers. These are called HMG CoA inhibitors. These are your statins, also known as, so you guys know this is your cholesterol medication.
Yes.
And then carbamazepine. This is a mood stabilizer. So if you want to make note of that, these are the 3 categories. You cannot give them grapefruit juice that I commonly see. Okay? Calcium channel blockers, as you know, that's the antihypertensive we just went over. It intensifies the effect. HMG CoA inhibitors, also known as your statins, like atorvastatin, simvastatin. These are used to treat high cholesterol, right? They're meant to lower the cholesterol for the patient. Those, you avoid grapefruit juice as well. And the last one is carbamazepine, which is a mood stabilizer. Again, you'll see it in psychotic disorders or bipolar disorders. And for those 3, no grapefruit juice. Okay? They either decrease absorption or intensify it. So, no grapefruit juice. Every good on the sartans? Again, sartans are pretty easy. There's not much to them. It's the angioedema and the hypotension. Okay. adrenergic blockers, also known as your alpha blockers, just like the beta, right? Betas were beta adrenergic blockers, but we just call them alpha or beta. We don't really mention the adrenergic, right? Just for short. These are your Zosins, such as the one that I usually see is Terazosin. Terazosin. Alright. These again, high blood pressure medications. Yes.
Oh, sorry, for the ARB, so, do we have any patient teaching specific?
They're specific other than what you would for the ACE inhibitor? No. I think it's just to like not, so they're gonna say for nurse administration, just, you know, you could take with or without food. And monitor for weight and edema, but again, it's just in case they're retaining fluid, but nothing specific for it.
Oh.
ARBs are really simple and easy. I don't see them as often for that reason, that they don't have any like major complications as their ACE inhibitors would.
Okay, so we don't have to taper those if we don't have to take it in? Okay, for the ARB.
For the ARB.
Okay, thank you.
Again, not very complicated. Sozin, for the alpha blocker, sorry, and then
Yeah,
this one, like with the ACE, they have what's called first dose orthostatic hypotension. So kind of what it sounds like, when they first start the medication, they're more prone to go ahead and have orthostatic hypotension. So again, patient teaching for this, rise slowly, right? So if they're in bed, sit up 1 minute, dangle your legs on the side of the bed, 1 minute, then stand up, right hand so that their body is slowly adjusting to their change in position. Make sure also for this one it's don't do anything that requires, for at least when they first begin the mist, do not do anything that requires mental alertness. You can feel tired or again dizzy from the orthostatic hypotension. Okay, that's the only complication for it. And then again, that's the patient teaching. Not, yes. So for this one, alpha, the only complication that it's focusing on is the first dose orthostatic hypotension. That means that when you first begin the medication, you're more prone, you're more likely to go ahead and have hypotension. For that reason, especially when they begin the med, do not do anything that requires mental alertness because they can feel dizzy, and then of course that causes as a safety measure. So other, I'm sorry? Rise slowly. So for that case as well, the other one that we're going over, I didn't write it on here, is rise, or they'll say change position slowly. And what does that mean? If they're laying down, sit them up, wait 1 minute. Right? Then dangle their legs and sit on the side of the bed, wait 1 minute. Then they can stand up, right? Like you're doing everything very slow so that their body adjusts to the change of position. Make sense?
Mm-hmm. No, we have 30 minutes, girl. Because we start G&D at 11:30. This class ends at 11.
Okay. Next, she wants to go over diuretics.
Only 2 hours.
Is everybody done with this? Alright, first one's first. High ceiling loop diuretics. This is your furosemide. Or ethacrynic acid. There's a few differences that I'll point out from the ethacrynic acid. These are also known, I'll put here, AKA loop diuretics. People out there call them water pills. Okay, you'll hear patients refer to them as that. Oh, it's my right, like water pills. Like people will mention that. It's loop diuretics. The technical name is high ceiling loop diuretic. People call them loop diuretics or water pills. Just patients will call them water pills sometimes. That's what they're. Yes, it's furosemide. That's the generic. And then this is ethacrynic acid. ETHACRYNIC.
I don't think I've heard of ethacrynic acid.
All right, to explain the effect, again, like diuretics, what this is making, especially this one, is it's making you void, right? It's making you urinate. However, where it's acting is specific on it. The reason why it's called a high ceiling loop diuretic is because it acts very high up on the loop of Henle in the kidney. So what that means is basically, you're gonna go ahead and take everything with you. Sodium, potassium, all your minerals and water is coming out in the void, right? So that's the key thing to know about this. All your minerals are being lost with it. You're just generally urinating. So what that'll cause is dehydration, for one. You could have hypotension due to the loss of fluid and sodium. Okay? Hypokalemia. Specifically, we worry about hypokalemia because, again, when they're lacking potassium, causes for cardiac arrhythmias, cardiac dysrhythmias. And then one that people tend to forget about because it's sort of odd is ototoxicity. Yeah, it'll affect the ear in that sense, okay? So the key point I want to say though is this: avoid with other ototoxic medications. So for this one, which is specifically gentamicin. Why are we avoiding gentamicin? It's an antibiotic. It also causes ototoxicity. So you're doubling the chance of that happening. Okay? Here's the thing about it. For furosemide, it could be called transient, which means it can go away. Ethacrynic acid, irreversible. How do you know this is happening? The symptom is tinnitus. Like tinnitus.
Tinnitus. Wait, mister, what do you mean by the furosemide and not? I don't know what.
So to explain, and I'll answer your question in one sec. To explain real quick, again, when I put here furosemide transient, ethacrynic irreversible. That means that if the patient is taking furosemide and they start having tinnitus, which is the ringing in the ears, basically, or you can think of it like that, and they stop the medication furosemide, there's a good chance it can go back to normal.
That's
with furosemide. With ethacrynic acid, once it begins, the likelihood and generally irreversible. They live with it. Yes. Okay.
So that's the ringing in the ears they live with?
Yes, so tinnitus is the symptom. So the questions that I see phrased along with this are, the patient is on furosemide, what would be a reason to discontinue the medication or something like that? It's tinnitus. Okay? And if you're wondering, if it's irreversible, right? I heard the statistic around that. I was reading an article. There's a couple million of people in the U.S. that live with tinnitus. Just, can you imagine that?
Hey, I hear that sometimes. I'm
Yeah,
like,
right. Like it goes in and out for myself sometimes as well. Like that's what I'm
Yeah.
saying.
You get that when you fire too many weapons too. No,
No,
literally in combat,
seriously,
you come back with
yeah.
tinnitus.
Come back with
Yeah,
the
yeah.
earring. I hear that sometimes.
Is that only a result of combining
Like-
it with the, or is it?
No, endocrinic acid is the medication. No. So furosemide is the medication. Endocrinic acid is the medication. They're both loop diuretics.
Oh.
They're
So-
both. These are the. It's a different, like saying lisinopril and captopril. Like it's. They're both medications. It's just called endocrinic acid. Okay, so these are the types of medications. So let's say I get a gentleman here, right, furosemide, and I give you endocrinic acid. You both have a chance of developing autotoxicity, right? Which means it's affecting your ear. Now, you avoid gentamicin regardless of the two because gentamicin also causes autotoxicity. However, he has furosemide, you have endocrinic. If you both have tinnitus, which means you start having that autotoxicity, if I stop the medication, since he was taking furosemide, his is reversible. He can probably go back to normal. You, that's it. You're gonna have
Can I get the other one?
What is the whole tinnitus? Like, what
Tinnitus is ringing in the ears.
Oh, so that only goes.
That's no, I just pointed it, that's the symptom. That's what you're gonna know.
For both.
Yes.
Okay.
So,
Thank you.
what would make the doctor prescribe the acid?
That is a good question as well. And I've never seen it prescribed. I always see
Furosemide.
furosemide.
So maybe
That's why everybody knows Lasix. Give them Lasix,
Yeah.
Lasix, right? Everybody's always Lasix.
Wait, mister.
So maybe outdated than the
Yeah,
acid.
it most likely took over. It's probably not even a thing anymore. Yeah.
Mr. Armando, so you're saying the furosemide, since it's like, it's transient or whatever you're saying, if you're taking it, just the furosemide alone, it's like, okay, you won't get the tinnitus, it can go away, but it can go
You
away.
still could.
Okay, but with the other one, with the
Yeah.
acid one?
So you can still get autotoxicity. You just avoid gentamicin because you're more likely to get it.
The
The autotoxicity.
Okay.
This is a technical name of what's happening. Tinnitus is the symptom. Does that make sense? Right? Like you can get a heart failure, right? But then what do you get, right? Chest pain. That's the symptom, right? You know that they may have it if they have the chest pain or their EKG is off. Yes.
What's the avoid
Gentamicin, it's an antibiotic.
So that's a symptom to autotoxicity, right?
All right, is everybody clear on this? So again, what do? You know, make sure that they're drinking enough water, 2 to 3 liters per day. You make sure they're intaking their minerals, right? Such as the their electrolytes, such as sodium, potassium, right? Because they're losing everything. So monitor for that. If they are in hypokalemia, what's our first worry? Cardiac arrhythmias. Every time they have no potassium or high potassium, the first thing you worry about is checking their heart. Some people immediately say, like, just taking action, right? Like you administer another medication or start CPR or something like that. I've seen questions like that. The first thing you do is do an EKG. You need to check that they're having an arrhythmia. If they don't have anything, then there's no reason to panic. Or I've seen people say like they have hypokalemia or they're taking furosemide, and then there's one on there that says give them a potassium supplement. No. Check the EKG, right? The first thing you do is assess. Always assess. Intervention is the third step in the nursing process. Assess, plan, intervene, evaluate. You need to assess the patient first. Okay, so always keep that in mind. I've seen people then get with that. Check the EKG. Hypotension, that's from the drop in fluid in their body. The less fluid, less blood pressure. Okay? Keep them hydrated, keep them with their electrolytes. Those are the key things for this.
Yeah. It is.
We started a little bit late. I'll give you 5 minutes and then we'll finish with this. Okay. So the last one we'll cover right now before we go on a quick little break. Very similar to this. Very similar to high ceiling loop diuretic. The only difference is it acts on a different part of the kidney. Still making them void, losing potassium, losing sodium, losing all their electrolytes and water. Okay, it just acts on a different part of the kidney. This one, less worry about, right? Or you don't have a worry about autotoxicity. Okay?
Did you write hypernatremia?
I'm sorry? Yes, hyponatremia. So low sodium, low potassium. Oh, sorry, not hyper. Sorry, Jesus. I see what you mean. I meant hypokalemia. I'm sorry. Right? Low sodium, low potassium. Right? They're losing their electrolytes. It's very similar to the loop diuretic, sorry. The only difference is it acts on a different part of the kidney. But you're still letting go of potassium, you're still letting go of sodium, of water. It's the general thing. And no autotoxicity. The category is called thiazide diuretics. There's only one medication that it phrases on there. It's called hydrochlorothiazide. This is dehydration. Hyponatremia. Sorry, Jesus. I'll write it neater. Hyponatremia. There, so it's neat. Or neater. I broke my arm. Leave me alone.
They don't judge on that, they don't judge.
Yeah, they don't judge.
Hyponatremia is
Low sodium.
Sodium.
All right. Low potassium. This is generally the first line, the first drug of choice for hypertension. Okay? Yes, again, stay hydrated. Again, the only thing that changes is no autotoxicity. Don't worry about teaching them about no gentamicin and all that. But still, rise slowly, change position slowly, watch blood pressure, give them enough fluids, give them their electrolytes. Yes. For hypertension, when somebody starts having hypertension, this is generally the first drug of choice.
It's not, it's for diuretic, so why don't you